Hi, we are here again with Dr. Brian Leany. He's a clinical psychologist from the University of Nevada, Las Vegas, and he worked largely in the public sector and forensic settings. And right now, he's going to talk to us about his work at one of the California state prisons. So I will turn it over to him. He's going to tell us a little bit about treatment in prison. So fire away, Dr. Leany.
So one of my first clinical settings was a maximum security level 4 prison in California.
Would this be like similar to San Quentin?
Exactly, and so San Quentin is another maximum security prison within the system, and level 4 for California, every state has their own classification, are the highest level of offenders. These are the most serious offenders. And on top of that, I worked both in the administrative segregation as well as the reception center.
Can you tell us what administrative segregation is?
Sure. So the administrative segregation is kind of like the jail within the prison. Okay. These are where individuals go who can't follow the rules within prison. They commit either another crime, so they commit a homicide, an assault, a battery, or drug use, something like that, but they violate some institutional rule that would send them there. And so it's basically where they're housed. And it's an isolation sort of facility. They're usually housed by themselves if it's possible. They can't leave anywhere without being escorted by security, whereas on the other yards they would have access to housing or to programs like education and vocational training and things like that.
And I'm going to actually have you start with telling us about your work in the reception center, but I am going to want to come back to aggregated segregation. So can you tell us what the reception center is and what you did there as a clinical psychologist?
Sure. And so the reception center is where the inmates go when they are first sentenced to prison. And this is where they get processed. They have their health checks, their mental health screening, dental checkups, and this is where they learn to be an inmate. You'd be surprised at the amount.
Orientation?
It is. It's exactly. It's an orientation. The number of rules they have to follow, learning how to do things. Okay. That's where they go to learn to do it. My job there was to screen them within, I believe it was 3 or 5 days of them coming in, to find those individuals that might have had a mental illness or currently are suffering from mental health symptoms. And if they were to refer them to the appropriate level of care, we had 3 levels of care within the prison. And it was the basic screening, and then they would get assigned. And so when they knew which prison they were going to, that prison would know what sort of treatment they needed to provide them.
Okay. All right, so you would screen for mental health and then refer accordingly.
Correct.
And in aggregated segregation, there you would provide treatment for people who had already been screened and determined to need mental health services. Is that?
So administrative segregation, as I said, was the jail within the prison, and there were different kinds of roles there. I was the clinician responsible for that area. We were assigned to different areas within this particular prison. That was my area. And you would treat individuals who were already in the mental health program, who had already been identified as needing treatment. But you would also see referrals for individuals who might be experiencing mental health symptoms for the first time, or those individuals that were acting erratic or acutely suicidal, acutely homicidal.
Can you tell us, Dr. Leany, just kind of briefly, standard treatment, for example, for depression is outpatient. So, I've treated depression on an outpatient basis where the client comes to me for 50 minutes a week, and I'm a cognitive behavioral therapist, and so I essentially, help them change their thoughts, their behaviors, all kind of with the idea that that's going to change how they're feeling. Can you tell us in a prison context how you would treat someone who has depression? Do you use protocols that are typically used as outpatient? How is it different? Tell us a little bit about that.
The prison setting is both kind of a blessing and a curse in the sense that you don't have the confidentiality or the means to do all the things that you would in a normal outpatient setting. But the benefit is that you know where your patient is. And
so you never have to worry about no-shows. They're there, so they show up.
They can refuse the treatment, but you know where they're at, and you can go ask them, well, why didn't you show up? Which you normally, you call a patient.
They can hide from you. They don't have to take your calls.
Right. And so that's the benefit. And a lot of times, especially in the administrative segregation setting, they were more willing to have that human contact that they were kind of deprived of and more willing to participate. But you would use the standard protocol as much as possible. Behavioral activation,
So
very easy.
Behavioral activation, so the idea with depression is When you hang out when you're depressed, you tend not to want to do anything, and the more you don't do anything, the more you feel depressed, and it's kind of like this cycle. And so, when you have a client come in for depression, the first thing you do is you help them come up with a list of things that they could engage in or do. And a lot of times, playing pleasant activities, things that they used to like to do, but maybe now they don't feel like doing. And then you send them out to do homework. So essentially, to engage in these tasks, even if they don't feel like it. Idea is that eventually their feelings will catch up with the actions that they're engaging in. So you're saying that you do employ kind of similar strategies in a prison setting, obviously with some modifications, because maybe they really used to like to dirt bike, but now they can't really do that given.
Right, and so the type of activities are significantly different, but you can still engage in a lot of the same things. They can journal, thoughts and feelings. You can do kind of ABC sort of therapy, the antecedent behavior and consequences. And so you can have them track those things just as you would in an outpatient. And the other benefit is that there's a multidisciplinary team. Most often in the prisons, you have psychiatric technicians, you have nursing, and you have those individuals that can say, hey, I observed this, and they're more readily available than they might be in a traditional setting to help give you collateral information about whether or not the individual is doing their homework or how they're doing day to day when you can't observe them.
Okay. And did you tend to see your clients on a weekly basis, less than a weekly basis? What was kind of the setup?
Well, and this is again where there's huge variation within the institution, but because my individuals were in a more highly restricted area, we were more concerned about their mental health because there was social isolation and there was deprivation of activities. And so I saw them at least once a week. Guys that were at a higher level of care, I would see them sometimes twice a week. And then along with that, we had regular multidisciplinary treatment meetings with the client patient as well as the entire treatment.
Okay, and a multidisciplinary treatment team meeting is a meeting where all people involved in the individual's care meet to discuss the case and to come up with a plan of action. If there's already a plan of action in place, just kind of seeing how that plan's going, making modifications to it accordingly. And as Dr. Leany said, usually, you've got on that staff a psychiatrist, a clinician, so whether it's a clinical psychologist or a marriage and family therapist, and then oftentimes a social worker.
And the interesting thing in corrections was you also had a correctional counselor that was present to help kind of guide some of the other programmatic needs that were outside of mental health treatment. So maybe education provision, or when they were paroling, or they can apply for Social Security disability if they're getting ready to go out. Those kinds of things.
Okay, and I do have one last question, Dr. Leany, if you could share with us in the context of the prison. If you have a client, in regular outpatient services, if I have a client who says, I'm suicidal, I have planned to hurt myself, I, essentially call 911. So my job is to ensure not ensure because I can't ever ensure, but to do everything that I can to ensure this person's safety. So in the prison setting, if we could kind of close, if you did have a client who was suicidal, what's standard protocol?
So let me back up a second. I think there are two important things to consider within the prison. The one is confidentiality is a big issue, and so informed consent is even more important because there's all these people around, and so you have to tell them, look, we can guarantee your confidentiality to the best of our ability, but people can overhear things because this is a secure institution and they have access, but to the best of our ability, we're going to protect that. But also, the things that we're mandated to report extend beyond just suicidality and homicidality, which is the traditional standard. We also have to report, as well as child and elder abuse, violating serious institutional rules. So if they tell us they're going to escape, that's not something you would normally tell. Report. If they tell us that they're using substances within the prison, we're supposed to report that as well as if they say they're going to smuggling contraband. Safety and security of the institution becomes a mandated reporting issue. Suicide is one of those mandated reporting that's across the globe, something that has to be reported. And the benefit of the prison setting is that they are secure and they are observed to a greater degree than even in an inpatient hospital setting. And what we do is we remind them that this is a mandated reporting issue. We notify the custody officers, and they're transported. In the institution I was at, we had a hospital there, a hospital unit that had a crisis bed, and so they could be housed there And if it was more than 10 days, they had to be referred to a state hospital, but traditionally they resolved these suicidal issues that were transient. But they would go there, they would be observed in a secure padded room. We would place them based on the level of risk. So if they had cut themselves while they're telling you, well, then that they need to probably be kind of stripped out and put in the padded room in one-on-one observations. But if they're just like, I can't get rid of these thoughts, I feel like I'm going to do something, they have a history, maybe you don't have to strip them out, you just put them in the observation. You don't remove their clothing, you're not afraid that they're going to try and hang themselves with their clothing. But those are considerations. And the additional risk with inmates is they just tend to be extra crafty. I don't know if that's the good word, but the things that they create and come up with would surprise you, and so you never really want to underestimate their ability or their determination to carry out something if they say they're going to do it. And so that would be the process. You would report it to the immediate custody officers there. You would arrange a transport. In our case, they would go to the hospital that was within the prison, and then they would be observed and treated until these symptoms resolved. And they usually would, and then they would return back to the unit. And you would follow that up. And a lot of times I would follow up at the hospital and say, hey, I want to check in and see how you're doing.
Okay. And I know I said that was my last question, but I actually do have two more questions, and I'll loop them in together. I've interviewed at a correctional setting and found that interview in and of itself to be very intimidating. And so, this may seem like a somewhat naive question, but did you feel safe in that setting? Were you ever assaulted or attacked? And if you were, would you be willing to share with us?
I think it's naive to feel safe in a prison. I mean, and especially in a level 4 prison where these are murderers and convicted killers that you're with. So you're always aware that something bad can happen. You would observe bad things happen. So there is the possibility that you're going to witness violence or somebody getting, even killed in this setting. But I felt very protected by the custody officer that I work with. I think the big thing in the prison setting and in forensics in general, or just is good practice all the way around, is being honest and upfront with everybody. And sometimes it's uncomfortable. It's probably the most uncomfortable thing to challenge somebody when they're telling you something that's untruthful or you're giving them bad news. I found the best way is I'm going to give you some bad news or some news that you're not going to like, and we'll talk about how to get through that. And so I think being honest was the big thing. And you have a reputation in prison, whether you like it or not. They're watching everything, and if you make a mistake and you're dishonest and aren't upfront, it's going to get around. The inmates aren't going to trust you. They may try and harm you if you do something without being upright or upfront. And the same thing with custody. If you don't cooperate with the correctional officers and follow the policies that are there, they're not going to be as willing to help you, unfortunately. I was assaulted once, if you can call it an assault. I had an inmate one time, and I knew it was going to happen. And so I had already started to kind of move to get myself out of that situation and getting ready. And
how did you know it was going to happen?
You work with these guys long enough that you start to get a feeling, and this wasn't even a patient of mine. This was somebody that was referred to me because of an acute crisis. He was saying he was suicidal, but really kind of contradicting everything that he was saying in terms of suicidality. And I think one of the things you got to be aware of is manipulation in the prison. Mm-hmm. And so I think he was actually just trying to get moved to a different unit. And so I had this conversation with him about being dishonest. But actually, he broke a rule, and this was a lapse on my part. He spit inside, and he was like within a contained booth.
Okay, and that's that's one thing that we didn't kind of talk about. So when it depends again, like on the correctional setting, but in some settings you will have, if you're working as a clinician in that setting, you will have your client, and they'll actually be in what I can't describe as anything other than a cage. Some distance away from you, and the guard will bring them in, lock them in to the cage, and so in that sense that you're safe. Is that typically how you would see your clients? Or
in the administrative segregation, that is the traditional format to see the clients, is they're in that cage because they have restricted movement and they're charged with another crime inside the prison, and so you're going to give them less benefit of the doubt. The reception center and every other yard in the prison, you would see them in an open office and they would just sit there freely.
So they wouldn't have handcuffs on or anything?
They would not be handcuffed unless there was some sort of immediate concern by the custody. And there were...
Is there a guard usually watching?
There should be one watching, but again, it's that balance between confidentiality and security.
Okay.
And so there is one always close by. It's up to the individual correctional officer and the clinician to decide where that
what
person's
levels of
at.
pain.
And what,
So in the instance where this client spit on you, was he inside the cage?
so we were in an office, and he was locked in the cage. This was the administrative segregation, and he spit, but he just spit out, and it was like he was angry. And once that happens, you don't want to breach confidentiality. I think that's the pull. You don't want to breach confidentiality. You don't want to be the custody officers. And so I don't want to report this individual. I don't want to be the one writing him up, because that's where the obligation would fall. I don't write citations. That's not my job. I'm a clinician. And so I probably should have cut him off there, but instead I brought it to his attention and said, hey, that's, would be considered an assaultive behavior. I don't want you to get in trouble. The custody is sitting right off of there. I want us to have a conversation about what's happening so I can figure out whether or not you're really dangerous to yourself, or whether we can figure out some sort of alternative, because it's going to confinement or isolation for observation is not fun either. So he started to calm down, but then got agitated again because I wasn't doing what he wanted. And so I started to get up to the door, and I said, look, I think we're going to end this. I don't think that this is, in your best interest to do this. And he just got irate again. And just as I was about to terminate the interview and get custody, he spit on me. And I was wearing, we have these stab-proof vests, which is another unique circumstance of correctional treatment. And he spit on the vest. He didn't get anything on me, but that's considered an assault. And that before I could even turn around, the custody officers were in the room. And
so they were watching, and they...
Right, it was no longer a treatment session. They were in there, and they restrained him, and he ended up also assaulting the custody officers. And so it was the first time I ever had somebody get that irate where they actually acted out towards me. I always felt like that room was the place for them to yell and scream and get angry. They can do that when they're talking about those things, and sometimes they're actively psychotic. But usually they would calm down, and it wasn't directed towards me. It was directed towards the system or other things, and we would get to a point where it would work out, and they would calm down. That wasn't the case with this individual, and it was the only time. And afterwards, I had a chance to talk with him, and things were not, he wasn't directly upset at me. Interestingly enough, he had a relative that was in the system and wanted to reassure me that things were okay, and this guy wasn't out to get me. Of course, I can't let him know that he's my client, but so probably the only time that anything ever happened. But you were always aware, and you should be aware when you're in that setting that bad things can happen. I mean, you're around people that have committed serious crimes. So.
Okay, well, thank you so much for your time. We appreciate it, and that concludes this segment of the lecture.